Hi, good evening, all. Thank you for joining. Gagna, just let me know when we can start. And in the meantime, shall I just share my screen and just let everyone check if they can see the screen?
Yes, yes, doctor.
Oh, that's perfect. It is planning to be interactive session. Entire screen.
Yeah, it's not full screen now.
Are you able to even see the side names?
No, no. Yeah,
It's
there
gone.
is a small bar like a Talking Mediversal Academy. That bar is
Yeah,
available.
I think we'll leave that there and I'll just take this bar up.
Okay, sure.
And my favorite, let me see if I can get my pointer. Perfect.
We have 3 minutes to go. We are waiting few more to join. Thank you.
ये क्या है हैं
हाँ 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 जल्दी आओ हमको अच्छा 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 इधर इधर सुनो
सब ठंडी तुम्हारी सब चाय ठंडी हो रही
ये
है
बेटा इधर आओ अरे बेटा हमको पेंसिल दे दो लिख दे जल्दी देते हैं पेंसिल दो
लो तुम करो
बस हो दो आपको ना भी मांगी
Hi, is my screen visible now?
One second. Am I audible?
Yes, loud and clear.
Yeah, thank you so much. Um,
Good evening to each and everyone over here. I'm thrilled to welcome you all for today's informative webinar on effective strategies for the management of diabetic ketoacidosis, DKA, our clinical approach. I'm Gagana Ballari, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for today, Dr. Alan Thomas. Dr. Alan Thomas, an MBBS graduate from CMC Vellore, furthered his education with a master's in general surgery at CMC Ludhiana. Currently working at CMC Vellore as junior faculty. He initiated his career in the resource limited regions of Uttarakhand and Uttar Pradesh, showcasing a strong commitment to excellence. Driven by his dedication, he earned a PG diploma in family medicine from CMC Vellore. Specializing further, Dr. Alan Thomas completed a PG fellowship in vascular surgery, earning FMAS fellowship recognition from AMASI. As a proud member of ASI, AMASI, and CMAI, he is also recognized for his prowess as a presenter, have been awarded Best Speaker at CARES 2022 Ludhiana. Thank you. Over to you, Dr. Alan.
Thank you, Gagna. And without wasting any further time, I'm really excited to start this talk on management of diabetic ketoacidosis. It is a real emergency. It can be called as an emergency medicine topic. It can be called as a medicine topic. And also, it has to do a lot with diabetology. So it's like an integration of multiple, I would say, very, very important, multiple streams of medicine, and a multidisciplinary approach needs to be there to manage diabetic ketoacidosis. Very, very important. Sugars, that the blood glucose needs to be managed well. If blood glucose goes beyond a particular level, and there's formation, which I'm going to talk about in the upcoming slides, about ketones, about how we're gonna look at a lot of things in diabetes ketoacidosis in a very short span of time. And I expect all of you to be really interactive, and of course I also want to learn more from you. And let's start this presentation. So, starting from the really, really grassroots level, what do you understand by diabetes? So, diabetes is a condition in the body that does not produce enough insulin or does not properly respond to insulin. The keywords are production or response. Even if insulin is there, if the receptors are not accepting insulin onto it, then also the patient can have diabetes, right? So insulin is a hormone produced in the pancreas. And what is the main role of insulin? The main role of insulin is to absorb the glucose. Okay, the glucose, enable the cells to absorb the glucose and in turn make the cell produce energy. So, as we all know, broadly classified, even though there are a couple of more types, but we would as of now. So, type 1, as we all know, is diagnosed in. Let me see if I can get a pointer. Yeah, children and young adults, previously known as juvenile diabetes, and now it's a separate. Insulin dependent. Body does not produce the insulin. Okay, very, very broad classification. Then if you look at found in overweight children also, non-insulin dependent, body fails to produce and use insulin, even though it's not insulin, it's non-insulin dependent. So what happens if you see this type 1 diabetes, the absence of insulin, it means these processes are unopposed, particularly the breakdown of muscle and fat. So you have the adrenaline, glucagon, cortisol. So adrenaline, lipolysis, glucagon. So you can see it will act on muscle and liver. And cortisol, gluconeogenesis means formation of more glucose. Glycogen breakdown is glycogenolysis. Fat or the lipids, when it breaks down, it produces energy. And also it breaks down into free fatty acids and ketone bodies. Very important to see here. So what happens? Blood glucose alterations. When complications of blood glucose alteration, either what can you have? Either you can have hypoglycemia, either you can have hyperglycemia, ketosis, acidosis or diabetic ketoacidosis. Means triad of hyperglycemia, ketosis, and acidosis. What are these? I'm going to explain in the upcoming slides. We're slowly building step by step, okay, starting from the ultra basics. Normal fasting blood glucose 70 to 100 milligrams per deciliter. Now, if you look at diabetic ketoacidosis, it's a serious and potential life-threatening complication. Okay, three main things you need to remember in this: hyperglycemia, metabolic acidosis, and ketonemia, ketonuria, excessive ketone body. Now, where is the ketone formed from? Here, go back to the previous slide. The lipid breakdown here on the first one, lipolysis, forms free fatty acids and ketone bodies. Ketones are also known as bad sugars. Now, DK, what happens? The diabetic ketoacidosis typically occurs due to, see, if you have the insulin, so the insulin is there. Normally, what happens? It enables the cells to uptake the glucose, the blood, right? So, what happens when there's a deficiency? The blood level of glucose rises. The glucose levels in the blood, it rises. And what happens? It leads to uncontrolled or absolute relative deficiency of insulin. What will it lead to? It will lead to uncontrolled lipolysis, breakdown of fats, ketogenesis, ketone formations, severe dehydration from osmotic diuresis. I'm going to explain in the upcoming slides. Definitely electrolyte imbalances. And it can even lead to cerebral edema if untreated. Prolonged untreated can even lead to death. Now, what are the spectrum of metabolic abnormalities you need to look at mainly in the diabetic ketoacidosis patients? So, two main things: insulin deficiency or resistance, glucagon excess, which may result from the removal of the normal suppressive effect of insulin. Okay, so other metabolic increased secretion of catecholamines, cortisol, growth hormone oppose the action of insulin. Means it will not let insulin act like it should. Okay. So also contributing to the increase in the glucose. Anything that leads, simple language, anything that leads to the increase in the glucose levels in the blood, okay, unopposed. And after that, it leads to a very dangerous level. And this ketone production also is there. So in simple languages, increased blood glucose levels to very high levels. Now, if you look at hospitalization rates, so there was an increase in 2009 to 2014, some studies have said, because SGLT2 inhibitors are class of drugs to lower the sugar, it's a diabetic drug. So that was recently discovered that time, and then they had introduced. So severe, because of that, also drug induced, you have there, and the hospitalization rates increase because of DK. Type 1 diabetes ketoacidosis, in patients with type 1 diabetes, the DKA is very, very high as compared to type 2. Because as I very well mentioned, you see in the beginning, let's go back to the initial slides, insulin dependent and non-insulin dependent. Insulin dependent is type 1 diabetes. Yeah. What are the predisposing factors for DKA? Shall we go to that? If you look at the predisposing factors, you have the inadequate insulin treatment or non-adherence. So sometimes the patient may have very high sugars. He would be a first diagnosed. Sometimes patient present in DK, he never knew he had diabetes. And when the sugar levels went very high, went to the hospital almost in a comatose state. That is when he realized, when he checked the sugars are 400, 500, 600, on the blood glucose or very high. So that's when they realized, okay, probably he is a diabetic. So inadequate insulin treatment or non-adherence. So if insulin is not, a patient is taking insulin and he does not take it correctly, times in a all that happens, then there's a possibility of patient going into DKA. Any acute infection, can actually precipitate diabetic ketoacidosis. Okay. And vice versa also. Infection 30 to 40%, stroke or transient ischemic attack, MI, acute pancreatitis, all that can, acute illnesses can. Pancreatitis, insulin production may not happen. Yeah. Drugs, therapy. Certain drugs are known to cause decay. Okay. What really happens in decay? Okay. So let's go 1 to 5, and this entire presentation is in your hands. Okay. So without insulin, glucose is unable to be processed by the body. Means it's in the bloodstream, but the cells are not able to take up the glucose because insulin is either not there, or even if it is there, the receptors are not active enough to take it. Then you come to the liver produces more glucose. When the body realizes the cells are hungry for glucose, the liver produces more glucose to produce the body. But without insulin, again, the glucose accumulates in the bloodstream. Okay. However, cells are further hungry. So cells need glucose, but they're not able to process or uptake of the glucose. So what happens? The number 3, the body needs to find an alternative source of energy and starts breaking down your fat. That's where lipolysis happens. The breakdown of fat produces ketones, which then builds up in the bloodstream. Everything is building up in the bloodstream, mind you. Okay. Then what happens? The ketones and glucose are transferred because above a particular level in the blood, okay, the kidneys start filtering them out. So that is why in diabetic patients, if the urine is left outside on the floor, you find ants eating on it. That's how even it was diagnosed whether there's diabetes and all that diagnosed because someone had urinated outside and the ants started feeding on them because it was rich in sugars. So the body tries to eliminate excess glucose and ketones. So ketones are transferred into the urine, and for that process, the body pulls out a lot of water to clear out the excess glucose and ketones from the blood. And last but not the least, if you see when the body tries to attempt get a lot of water out, this can lead to dehydration. And that dehydration, it's a vicious cycle. That dehydration will further lead to ketoacidosis. Again, what are the presenting complaints? Can anyone put in the chat box what could be the presenting complaints? Because I've explained also looking at different segments. If you look at how DK presents, I would like to put forward in the chat box. How would DK present? What are the presenting complaints? Any yes, perfect iPhone. I mean, is that a name? Oh no, that's a phone. Okay. Vomiting, pain, abdomen, nausea, very good. More importantly, some more important this one. Yes. Come on. Kusumal's breathing, very good. Thirst, very good. Shortness of breath, very, very important. Breathlessness. Polyuria. So yeah, as you know, the previous slide I've explained how this polyuria, because the body is trying to eliminate glucose and ketones. So in that process, a large amount of water is also pulled out. So that is polyuria, okay. And because when a lot of water is gone, then there's dehydration, blood vision, excellent. Zao Bawadi Health Post, excellent blood vision. Okay. So moving forward, in simple language, you can either have a gastroenteritis kind of picture, vomiting but no diarrhea, dehydration but excessive urine output. Okay, this kind of very weird kind of clinical presentation, respiratory distress but no lung findings. So this is just a summary of the presentations. So as mentioned, either deep and rapid breathing, fruity odor, very dry mouth, nausea and vomiting, lethargy, drowsiness, DK is life-threatening and needs immediate treatment. Some more symptoms: abdominal pain, fatigue, confusion, some blurred vision, polydipsia, polyuria. Yeah, Dr. Mahesh, bicarb less than 15. Well, that is more in terms of investigations. Right now, we're discussing, the finding, the physical history and findings. Yeah. Perfect. So moving forward, physical examination, hypotension. It's the same symptoms if you can translate into, you'll have a dry tongue, dry mucous membrane, confusion, some abdominal tenderness will be there, Kusumal's breathing like deep labored breaths, hypotension, possible tachycardia. How do I classify DK? Is it how if you're junior or somebody or you're trying to communicate with your senior, how will you say the person is not there, the senior is not around, and you're trying to communicate over phone? How would you say that whether class what is the classification of DK? The patient that presents, whether it's mild, moderate, or severe. Okay, this is a table that's taken from Up to Date. So if you look at a few things, as Dr. Mahesh has also very well pointed out, serum bicarbonate, plasma glucose, arterial pH, urine ketones, and serum ketones. Urine ketones is quite easy to do because of something known as a urine dipstick test. It's a point of care test. And anion gap, alteration in the sensorium, mental obtundation. HHS is nothing but it's another version, hyperosmolar version of. It's not exactly DK. It's again a condition that happens in very very high. It has a higher mortality than DK. We're not discussing that as of now. We're only discussing DK for today, and hyperosmolar hyperglycemic state that is there, and it's quite bad mortality. You would see more of a presentation of a DK than HHS. So just to put it in a box, mild DK, moderate DK, severe DK. Can mild is arterial pH, the ABG 7.25 to 35, moderate is 7 to 7.24, severe is less than 7. Then you look at serum bicarbonate 15 to 18, 10 to 15, and less than 10. Severe DK is less than 10. Anion gap is elevated, again greater than 12. Greater than 12 tells you the level of acidosis. Mental status, blood glucose greater than 250 milligrams per deciliter. And serum ketones are positive in all of them. So what are the key points in classification you need to see? You need to see anion gap. Now, how do I calculate anion gap? I have sodium minus chloride plus bicarb. This value you will get from your arterial blood gas analysis. So based on that, you will be able to calculate anion gap. The newer blood gas analyzers, they give you an anion gap also calculate and give you. And serum ketones, beta hydroxybutyrate is a predominant ketone in DK and can be quantified for monitoring the severity. Now, what are the changes? Mental status, alertness to stupor or coma, again, reflects in severity of DK. As you can see, if you see mental status is kind of alert, some drowsiness, and stupor or coma in severe DK. So how do I classify? Again, classifying the investigations. So I would classify investigations, initial diagnose. I need to make a diagnosis whether, yes, the person has a diabetic ketoacidosis or not. Then I need to find out, I need to know investigations which will help me identify the precipitating factors. What led to DK? Initially, I need to confirm whether it's a DKA or not. Then I need to confirm or rather find out what are the precipitating factors. And the last is you can see once I identify the precipitating factors and treat it, I diagnosed a DK. Now I need to monitor. When should I stop my resuscitation work? When can I say the patient is well and can go home? So those are the tests for monitoring. So if you look at initial diagnostic tests aimed at confirming DK, you have the blood glucose levels, arterial blood gas analysis, mild. Again, this is again revision of the same. pH values, blood gas analysis, then PaCO2, partial pressure of carbon dioxide, low due to compensatory hyperventilation. This is your Kussmaul's breathing, deep and labored breathing. Serum bicarbonate, okay? Low less than 18 indicates somewhat metabolic acidosis, 15 to 18, moderate 10 to 15, and yes, less than 10. Ketones, positive ketones can confirm ketoacidosis. High sugars, simple one-liner. A patient comes in a comatose state, somebody says he's diabetic. Either he can be hypoglycemia, or as soon as you do the sugar, and if it says high or more than 250 plus, then definitely try to get a ketone level, either serum or urine. If he's catheterize him, get some urine, put the dipstick. See, if urine ketones are also positive, then he's probably in DKA. Okay, then you can keep sending your ABG and all that. It's a dipstick, and then definitely you need to look at the electrolytes. Now, how do I identify the precipitating factors? Initially, if you remember, I had a slide on predisposing factors. Okay, so looking at an infection workup, cultures, urine culture, chest X-ray to rule out pneumonia, CRP or procalcitonin are markers of infection. CBC to look for any left shift of the neutrophils. Yeah. Cardiac workup, electrocardiogram, ECG, echo, and is MI a cause of decay, especially in patients with electrolyte imbalances? Very important is to detect arrhythmias or MI, especially in patients with electrolyte imbalances. Troponins to rule out any myocardial infarction. Other tests, thyroid function, if thyroid storm is suspected, amylase lipase to rule out pancreatitis. Now we come to the monitoring tests. So we have looked at identification, then identification of the precipitating factors, diagnosis, identification of precipitating factors, and now we look at the monitoring test. So you have to sequentially keep checking the blood glucose levels. A patient is on infusion, you have to check hourly and then guide the insulin therapy accordingly. Electrolytes, very important. At least you need to do it 4 to 6 hourly to see, okay, whether patient is, going into hypokalemia during the treatment. Because what happens when insulin infusion is going on, the potassium levels can drop. Okay, it is a mechanism, but you just for your clinical understanding, insulin is given. You need to also check for potassium. If potassium is very low, you should try and avoid giving insulin. Okay, sodium chloride to monitor fluid status, electrolyte balance, serum ketones checked almost every 2 to 4 hours to resolve, and you'll find once the treatment is initiated, you'll find the levels of ketones coming down. Reassess the acidosis periodically, 6 hourly at least. And blood urea nitrogen creatinine to monitor kidney function and hydration status, very important. Urine output is very important to check. And phosphate rarely go down, so supplementation if required. So this is a summary slide of why we do what we do. So blood glucose to confirm the hyperglycemia, ABG assessing the acidosis, bicarb, severity of metabolic acidosis, ketones to confirm the ketoacidosis, anion gap detecting metabolic acidosis, electrolytes assessing the fluid and electrolyte imbalances, cultures to detect the infections, ECG detect cardiac complications of the same. Monitoring is by glucose and electrolytes regularly we do to track the response to treatment. Now we come to a very essential part of the presentation, is the treatment part of diabetic ketoacidosis. Everything has principles, okay? Principles of treatment, preferably the patient has to be managed in a HDU or ICU setting, mainly because this patient requires monitoring, requires effort of the doctor, the staff, to regularly keep changing the insulin dose. You cannot just leave infusion pump in the ward and just come back in the evening and check it, because patient may go into hypoglycemia. You may need to titrate the insulin dosing. So preferably in an HDU or ICU setting where the percentage of doctors and staff to bed ratio is high, it's better. Careful replacement of fluid deficits, correction of acidosis, correction of the electrolyte imbalance, treatment of the underlying cause, monitoring the complications of treatment. So what will you do in the initial hospital? As soon as the patient is brought to you, replace the fluid. Diagnosis should be made first, and the start of fluids, IV insulin therapy, glucose administration may be required. If the patient is in hypoglycemia, watch for the complications and disconnect insulin pump as soon as sugars are at a particular level. So once resolved, you have to convert to home insulin regime and prevent recurrence. Education, health education is very, very important. And patient may be on particular level of insulin. So you can either shift to his regular doses of insulin and monitor him and see if he's responding to that, titrate it accordingly. So as soon as the patient presents to you, you stabilize the patient because he may be in a comatose state or you may be in a very stupor state. Patient's airway, breathing, and circulation, very, very important. Large IV bore access using a cardiac monitor, monitor. Capnography may or may not be possible in our setting. And pulse oximetry, very important. Look at saturation levels. Serum glucose should be monitored hourly. Basic electrolytes, 4 to 6 hourly. Creatinine, at least 6 to 8 hourly. Ketones every 2 to 4 hourly. Venous phase of bicarbonate every 4 hours until the patient is stable. So once you identify and manage the underlying cause of DKA, like pneumonia, UTI, MI, intentional withholding of insulin, patient has forgotten to take the insulin, blood levels shot up. Nowadays, it's a lot of festival season. People are eating sweets. They may forget to take the insulin, or they may go to different places, forget to carry their insulin. So in those cases, yes, there's a possibility of the patient going into diabetic ketoacidosis. Now, fluid and electrolyte management, the ECF volume and the free water deficits have to be repleted because that is lost. As I told you, there's dehydration. In patients are presenting in hypotension shock, administer several liters of IV isotonic fluid or buffered crystalloid as rapidly as possible. Hypovolemia, but without shock, without signs of kidney compromise or cardiac compromise, administer IV isotonic 0.9 saline at the rate of 0.5 to 1 liter per hour for the first few hours. You need to do that because the patient is dehydrated. You should understand that, and you're repleting it. Okay. Hypovolemia without shock, without signs of cardiac and kidney compromise. Patients with mild hypovolemia individualize the fluid replacement. And once the intravascular volume is restored, dry tongue and all that is not there, look at, your corrected sodium. Then corrected sodium is normal or elevated, give N/2 saline at 250 to 500 ml per hour. You come down after that, after the volume is restored. Then you look at, it's still low, continue isotonic saline until hyponatremia resolves. So as I told you previously, also there will be electrolyte imbalances which you need to sort. Even though patient, you might wonder what is the last line. Even though patient is having high glucose, so once you started insulin therapy, there is a possibility that it will go below a particular level. Okay, so less than 250 to 200, you need to switch over from the saline to something known as 5 to 10% dextrose along with the insulin infusion. Or you may even have to stop the insulin infusion. So you switch over the dextrose so that patient will not go into severe hypoglycemia. Potassium replete needs to be repleted. Regardless of the initial measurement of serum potassium, most patients with diabetic ketoacidosis have a large total body potassium deficit. Okay. Now, how will I manage the potassium? Three things. I know even though so much text is written here because I know this is an important slide. Less than 3.5, 3.5 to 5, and 5. Is less than 3.5, delay the initiation of insulin and give potassium chloride per hour until the potassium concentration rises up to 3.5. Rarely addition because hypokalemia can kill the patient. Okay, that can cause cardiac arrhythmias. 3.5 to 5 potassium chloride is given per 20 milligrams per IV liter of fluid. Maintain the serum potassium between 4 to 5 milliequivalents per liter. Do not give potassium if the initial value is, greater than 5 milliequivalents. Check serum potassium at least every 2 hours. Administer potassium chloride as needed to maintain the serum potassium between 4 to 5 milliequivalents per liter. So if the potassium is less than 3.5, do not give insulin because insulin will further push the potassium down. So replete the potassium and fluid deficit first. For patients with potassium greater than, give regular insulin using the either regimen, either a fixed rate continuous IV, that is your infusion pump, 0.1 units per kg per hour. If establishing venous access is delayed, then what you need to do, just give off an IV bolus prior to continuous infusion. Variable rate continuous IV infusion determined by nurse-driven protocol. It's very, very important. You need to have a dedicated staff looking at all this, insulin infusion and all that, preferably so that the patient does not go into hypoglycemia because insulin is being continuously infused through a pump. So how will I know whether my insulin is really working or not? So when I check the sugars every hourly, if the sugar levels does not fall by at least 50 to 70, then double the rate of insulin infusion. Okay. So when every hour when you're checking on serum glucose is less than 250, reaches less than to decrease the infusion rate to 0.05 units per kg. Earlier we were looking at 0.1. Now reduce that to half. Simple. I will revise this again with you now. Adjust the rate as further needed to maintain the glucose at approximately 200 milligram per deciliter. Continue the insulin infusion until ketoacidosis is resolved. Serum glucose is below 200 and then subsequent insulin is also begun. Because at some point of time, you may have to stop the insulin infusion. So again, revising the part, this is potassium. So for fixed rate IV insulin, if the potassium is more than 3.5, give the regular insulin using either the regimen, that is fixed rate insulin, 0.1 kg per hour. Okay, IV access, not access a dehydrated veins, you cannot get, at least somehow get a vein and give off a bolus of 0.1 unit per kg bolus prior to the infusion. If it's a 60 kg man, per unit per kg around 6 units, at least you'll have to give at least 6 to 10 units you may have to give bolus prior to continuous infusion. And once you have reached your targeted less than 250, you have to decrease the levels to half, 0.05 units per kg per hour. So that is that. But sometimes they may not respond. If the sugar levels from 600, it falls to say 590. It's hardly fallen. Okay, 10. It's not, for at least it should fall by 50 to 70. Otherwise, if it doesn't fall, then in the first hour, at the end of first hour, if it doesn't fall this much, by 50, it has to be at least, with 600, it has to be at least 550 or 500. If it doesn't fall at that rate, okay, rate of falling, once your infusion done, you have to double the rate of insulin infusion. If the arterial pH is less than 7, bicarbonates and phosphates may be indicated, but that's quite rare. If severe acidosis, you may consider giving 100 milliequivalents of sodium bicarbonate in 400 ml of sterile water over 2 hours. And potassium is less than 5. You can add 20 mg potassium chloride at the same time. Bicarbonate administration may be repeated as needed to raise the pH above 7. Okay. The normal pH value is between 7.35 to 7.45. It's a range. So less than that, like severe acidosis will be less than 7. So in that case, you need to really consider giving bicarbonate. You look at the complications of decay. If you see, infection can actually precipitate the decay, fever, shock, vascular thrombosis, pulmonary edema, cerebral edema, possible in the first 24 hours. Treatment is mannitol, may require even intubation and hyperventilation. how do I prevent DK? Education, education, education. Very, very important. Then you need to, at home, our diabetic patients should be advised to buy glucometers and check regularly the blood glucose level. Careful titration of the insulin. If they're on regular insulin, then they need to check their glucose and then accordingly use the insulin. And if they fall ill for any reason, pneumonia or any form of infection, then the amount of blood glucose checking should go up at a regular interval to see if they're not going into hyper or hypoglycemia. Education in type 2 diabetes, education, frequent checking of blood glucose, and frequent monitoring when ill. So these are some of my references, and up to date is also a reference I have used. And I believe this was quite a useful class to many. And now we can, even ask some questions. And Gagna, can you open the floor for questions? I'm really waiting to. So I'm stopping my screen share for now. I hope this was class. I try to make it as simple as possible. It is not a simple topic to understand in one shot. So I understand you need to read about it. And I hope this presentation, this lecture was useful to understand the basics. I was able to provide a skeleton into understanding, diabetic ketoacidosis. Yes, if you know at least these basics, you will be able to manage your patients. This presentation is for many of you who are managing different nursing homes, hospitals alone, mission hospital doctors who are single-handedly managing a lot of factors, Mediversal has really taken the effort to bring forward this free webinars, especially for the mission hospital doctors who are working in very, very remote areas and trying to serve people. So yes, if any of you are interested to work in in a very rural setup, where challenging situations and very, very areas of need, where your one decision can really make changes in the life of the patient, and definitely come forward and contact us, and then definitely we can talk to the hospitals. We have tie up with 55 plus hospitals throughout the country, and many of which are definitely in remote, resource limited settings, with consultants who are really willing to teach you, and are bringing forward different experience of medicine. So we will can definitely get you in contact with them and try and post you there. I'm not sure about the stipend part. Which type? There are some hospitals that provide stipend also, short-term courses for that. Gagna, you need to contact Gagna, and from there we can try and coordinate with the hospitals and try and post you there. So yes, we do have hospital attachments that provide certain kind of clinical attachments, provide experience to you. So get in touch with Gagna, and then she will take it on from there
Sure,
and
sure.
give you the list of hospitals. Yeah, over to
Yeah.
Gagna.
Yeah, sure. We have across 45 plus hospital association with us, like where we'll be placing for the clinical attachments. If anybody is interested, we'll also give additional discount for the candidates who have enrolled through this webinar. The discount code will be Alan15, so that you will get instant 15% discount applied. So for that, you can contact this number I'm dropping in the chat box. Kindly contact the same number. Doctor, can I open the floor for the questions? Doctor?
Yeah, sure.
Just
Yeah.
just give me a moment. There are two questions. I'll just drop a number in the chat box and I'll get on the same.
Thank you, Dr. Mahesh.
Kindly
Yeah.
drop your inquiries in the same number. We will be answering your all queries. Thank you. And this is the coupon code where you can apply this and you will get instant 15% discount. Yeah.
Yeah, Gagna, open the floor for questions, please.
Yeah, sure. Thank you. We have a question from Zabovadi Health Post. How to manage hypoxemia, whether to go for intubation or not, as I have read somewhere, that is avoided to prevent hemodynamic collapse. Is potassium bicarbonate contraindicated in individuals with frank DKA?
Right. So thank you for the question. So yes, I would like to, run your minds through the basic resuscitation protocol that we are all studied, the BLS and the ACLS. So all of them, okay, what do they say? Mainly the BLS, this is um, uh, airway, breathing, and circulation, right? So when a patient is hypoxemic, not able to breathe, he's having an airway compromise for whatsoever reason, he is not, is not able to take in oxygen, then definitely you might have to intubate the patient. So airway is coming first, breathing and circulation. Right. So you may need to intubate this patient if the patient is coming in a comatose state. What happens in many of our homes and otherwise also when somebody collapses, it's a natural reflex to give him water. So sometimes patient may aspirate water. So that will worsen his breathing. So you may have to, and he may have develop some form of aspiration before he reaches the hospital. So even that is a very serious condition. So at that same time, you may have to intubate the patient. It's all a clinical judgment that as the patient presents to you in the emergency department, if he's not able to breathe, secure the airway first. And then follow the same ABC protocol. And yes, once he is conscious enough, he's able to, his sensorium improves. Of course, you can always extubate him. And looking at the next question, is potassium or bicarbonate contraindicated in individuals with frank DK? Well, there's nothing known as frank DK either. There is mild, moderate, or severe DK. So if the potassium is above, when you're checking the blood electrolyte levels, potassium is above your 5 points, then avoid giving potassium. Okay, so if it is low, then you'll have to correct the potassium first. So that is very, very important because insulin, as soon as you pump in, again, it will lead to hypokalemia. And hypokalemia is a very dangerous situation. It can lead to cardiac arrhythmias, and the patient can collapse not because of your treatment, but because of the electrolyte imbalance that has happened. ECG also will show hypokalemic changes that are there. So treat the electrolyte imbalances also. At the same time, you're giving IV fluids to take care of his dehydration, etc.
I'm waiting for the second question. Just a moment. Certificate link. Thank you, Dr. Alan G. Is what Zobavadi is saying. Thank you so much. And
Yeah, I hope I was able to answer that.
kindly drop your questions in the chat box. We'll do our best to answer them. Dr. Samuel Mujassim will be sharing the certificate link once we end with the Q&A session. Kindly please wait for a moment. Additionally, I'm dropping the WhatsApp channel link. Kindly do subscribe and follow us on WhatsApp channel and all the social media handles.
Gagna, there are a couple of questions which have been asked in the WhatsApp group that we all are there. So, the question I'll read out. The question says, what are the main electrolyte abnormalities in DK? Yeah. Thank you, Rahul, for that question. The main electrolyte abnormalities, as we know, is mainly potassium and sodium. So potassium would be priority number one, and then you need to look at sodium. And then the others may or may not, really look into it, but like phosphates and all. But if it is low, you may have to supplement. I hope that answers the question.
Thank you.
Yeah. One more question by Zaina.
Okay. Just give me.
How can dehydration in DKA be identified clinically? Wow, that's a good question. Thank you, Zaina. So what happens is when the patient presents clinically to you, you look at his mucous membranes like the tongue, under the eye, you look at eye, sunken eyes or not. You can lift the skin and see this. If there's a skin turgor. How's the skin turgor? Whether it's easily pinchable and have the wrinkles and all. You know that he's in dehydration. Of course, either on history, if the patient is not catheterized, he will say my urine output has dropped. The relative will say he has not passed urine for the entire day. So that also is a sign that the body is trying to conserve the water in the body. Body is trying to conserve the water to prevent dehydration from worsening. So kidneys will go into something known as acute kidney shutdown. So to prevent further loss of water in the form of urine. So I hope that even answers the question.
Sure. Dr. Alan G, can I take a moment?
Yes, please.
Yeah. I have dropped a link in the chat box for you to fill out and submit to get your certificate of participation. Kindly fill the form and submit it. Thank you, Alan G. You can continue.
Yeah, I had only two questions for now. Let me see if my other group has also some questions. I think we should add all of them to the groups
Yes.
so that this regular clinical that we have started recently, the clinical case scenarios.
Yeah.
Can you just give a quick overview of that also, Gagna, the clinical case scenarios? So if you have not, joined our free groups where we talk about different scenarios, case scenarios, and how to manage them, it's a free of cost channel that you can join where all these updates are also there. You can leave your phone numbers personally to Gagna right now on the chat box. You can just leave it to them and we can add you to the group. So you will be able to get the updates and also the clinical scenario, clinical case presentations that are there. That happens almost every week, I believe, apart from these webinars. One more question has come. How can continuous glucose monitoring, that is the CGM or insulin pump therapy, help in reducing the risk of decay? First of all, we need to know what is this continuous glucose monitoring. So continuous glucose monitoring is nothing, but you need to understand it's a small device that is used. It's fixed on the patient's arm or abdomen, and every minute it keeps reading the sugars. It's a small device. It's kept for about 7 days, 7 to 14 days, and it's got a reader is separate. And after that, you take that out and the reader, it's placed a wireless thing, it's placed onto the reader, and it'll give you a 14-day or a 7 to 14-day average of every hourly reading of how the sugars were. And if your sugars, when this device is put, it's an external device attached. So when the device is put, they ask for some emergency numbers. So in case, sugars go very low at any particular time of the day or night, emergency contacts are activated. Um, and the messages are sent to them that the sugars are quite low for this particular patient. So you should understand that is something known as continuous glucose monitoring. They are used devices that are used for patients who are not, being able to manage their sugars. They have very, very high readings or very low readings. So as soon as you give medication, goes very low, very erratic kind of reading. So they understand over a period of 7 to 14 days, whatever they eat, is it really shooting up the sugars at what particular level? So they're able to titrate the food, and they will know at what time the sugars are going up. So yeah, so that is your continuous glucose monitoring. Well, will that help in reducing the risk of decay? Well, if your sugars are under control, then definitely, that will help. If your sugars are uncontrolled or very high levels of sugars, then only you have a chance of going into decay. So yeah, CGM can help, understanding your blood glucose pattern, and then you can titrate the doses of insulin and drugs accordingly. So yes, these have been the questions till now. Any other questions from the existing audience?
Kindly please drop your questions in the chat box. We'll do best to answer them. Sure, Dr. Noor E. Iftisam, we'll be adding you to the group. I'll be sharing you the link in the WhatsApp. Kindly please join the group.
Yeah, you can also send your personal WhatsApp numbers to Gagna, and maybe also the subjects that you're interested in. We can also look into the case scenarios based on your subject of preference. And we have introduced some courses also that are there. So Gagna can give an overview of Mediversal's basic courses that are there, that talks about management of patients and everything. And the clinical attachment is what we do concentrate in, providing doctors like you throughout the country, at different places, provide good experience to them, attach you to doctors that are there. And yes, at the end of it, you get a experience certificate or an observership certificate. Also, Gagna, if you could also give a brief overview of our stipend programs that are there.
Yes.
At some hospitals, you can contact, if anybody is looking for jobs. We do have stipend programs along with courses.
Yeah, actually, we do have a specialized program which is running out for PG diploma and fellowship, mainly for fellowship with clinical attachments. So we do have 12 months stipend courses where we provide stipend of 40,000 with accommodation at SMH Hospital, which is located in Ranipet. Like it is like we'll be giving in-house accommodation, like where in the campus only there will be an accommodation, and also it is a 12 months of stipend program which we provide. The course fee is 1,75,000, and for today's offer you will be getting instant 25,000 off, and it will be up to 1,50,000. Sure, Dr. Ankur, we will be giving you the PPT. Dr. Nazia have already shared you the link in the WhatsApp. Kindly join the WhatsApp group.
I hope this presentation was useful, and if you could leave that feedback in the chat box, it'll be great.
I have already dropped a link in the chat box for you to fill and submit the feedback and certificate form to get your participation certificate. Your feedback is valuable to us. Kindly drop your valuable feedback. Alan, I hope there are no questions.
Sure. Then we can call it a day. And we look forward for more webinars that are soon going to be there. And
Waiting for your webinars, Doctor.
yeah, sure. Thank you.
There is a one question from Dr. Ankur: starvation ketoacidosis.
Sorry.
Starvation ketoacidosis.
Okay. So starvation ketoacidosis, what happens is somebody when you're this is actually a voluntary kind of thing and you're trying to you know deprive the body of glucose for a prolonged period. What happens is again the similar pattern. um, your blood glucose, you're actually the body will try to find out more other sources of energy, and that's when your muscle breakdown and your fat breakdown will happen. Genolysis, your glycogen lysis, and you have lipolysis. So in all of these conditions, the ketones are developed in the body. So you will have a ketoacidosis, but you will this cannot be called as a diabetic ketoacidosis. Diabetic ketoacidosis is a condition where sugar. The primary condition is your blood glucose levels have to be very high. Okay. So the other thing is in starvation ketoacidosis, your treatment is mainly your IV dextrose itself. You have to give sugars, your IV fluid. So IV dextrose, your electrolyte replacement, and supplemental oxygen may be required. So yes, you need to look at that, but this is not the same as DKA. But the ketoacidosis part, yes, ketones are formed, and because of that, because of severe again dehydration and all that, if, patient becomes quite unwell and he needs to be rushed to the hospital. So there are ketone bodies that are accumulated in the bloodstream.
Thank you, Doctor. Thank you for answering the questions. Can we wait for 2 more minutes or can we wait?
As you say, Gagna, you're the boss.
Thank you. No. Actually, like as previously Dr. Alan G said, like we are running case series. Those who answers to the case series in our Instagram channel, for the top contributors, we will be giving, or the top contributors will be receiving certificates of excellence from Mediversal Academy and customized up-to-date CME access. So they'll be getting customized up-to-date CME access for the desired specialization of the candidate. We will be giving this to, as a top contributors will receive this as a rewards to the top contributors. So kindly do answer all the case series answers, like whatever you get and whatever so that you might be the top contributors among all of them. So that you will be receiving customized up to date CME access certificate of excellence. This up to date is something like it's like a Wikipedia where you get all the information or all the course content in one platform, so where you can upskill and gain knowledge from the up to date. So don't miss the opportunity.
Just to add on to that, sorry to interrupt, Gagna, just to add on that, it is evidence-based medicine. It will tell you the update from all the journals, everything. It will collate, and then, on that topic, it will collate and tell you and give you an answer, your treatment protocol and all that. Today's, a lot of my topic has been, taken, the content has been taken from UpToDate, and it's it's the recent guidelines for treatment of different conditions that you can face, and it's quite expensive also.
Yeah.
Getting that one.
And
so that custom made thing, Gagna,
yeah,
that's very good to hear.
thank you so
The
much.
top contributors would be getting that.
Yeah, and also kindly don't miss the opportunity, grab the opportunity and start answering to all our case series so that you will be getting certificates of excellence and as well as customized up-to-date CME access. And also upon that, you will be having minimal free access to our continual medical education live webinars.
Okay, Gangna, we'll call it a day then.
Sure, sure.
Thank you, everyone.
Thank you. I have also dropped the link in the chat box. Kindly, please do fill and submit your certificate form so that you will get your participation certificates. Before we conclude, we would like to thank you each and everyone for joining us today. We hope you found this webinar informative and valuable. If you have any further questions or would like more information, please feel free to reach out to us. I have already dropped a number in the chat box. Kindly drop your questions or any queries you have. Additionally, as I already informed you about stipend courses we have at SMH, kindly please do contact me for further queries and for further doubts. Additionally, we have already dropped a link in the chat box for you to fill out and submit to receive your certificates of participation. Don't miss to answer our case series in the Instagram so that you will be top contributors one day, and we would be happy to give you the top contributors rewards and awards. Don't forget to follow us on social media for updates on future webinars and events. Have a great evening. Thank you, Doctor.
Thank you.
Thank you so much for the
Bye.
wonderful session we had today. Thanks a lot.